Hello everyone. We will take a few minutes to talk something about the pathogenesis of immune thrombocytopenia. As everybody knows, immune thrombocytopenia is a very common bleeding disorder, which is acquired immune disorders. Like many other immune disorders, the pathogenesis is a loss of tolerance to autoantigen. And in immune thrombocytopenia, the antigen is a platelet glycoprotein specific antigens. So the loss of immune tolerance to glycoprotein play a pivotal role in the disease. And the consequence of loss of tolerance divided into two. First one is an immune-mediated megakaryocytopoiesis deficiency. As everybody knows, in ITP, the megakaryocyte number is normal or increased in the bone marrow. However, the platelet production rate is decreased. And the reason for that is on the surface of megakaryocyte, there are also antigens which is very similar to platelet antigens. Therefore, the antibodies or immune cytotoxic T cells will target not only platelet but also megakaryocyte. And this may cause a megakaryocyte para-apoptosis, which leading to a deficient platelet production. So that's one. And the second consequence of loss of immune tolerance is a immune-mediated platelet destruction, overdestruction. And there are three kinds of overdestruction. The first one is a humoral immune mediated, that is antibody or autoantibody mediated destruction via the monocyte macrophages. There are Fc receptors on the surface of macrophages. So the Fc portion of the autoantibody may bind these Fc receptors, which mediate with the help of co-stimulating factors cause a phagocytosis of the antibody-coated platelet. And the second way of platelet destruction is that the platelet might be destructed directly by cytotoxic T cells, which is cellular immune mechanism, which is not dependent on the antibodies. Without the help of antibodies, and the cytotoxic T cell may destroy the platelet directly, lyse the platelet by making holes on the membrane of platelet through secreting granzyme B and perforin. And the third way of platelet destruction, which is recognized quite recently by Dr. Haiyu Ni and our group, we found that the platelet might be destroyed not only depend on autoantibodies, not only depend on cytotoxic T cells, but also it can be destroyed through a mechanism happened in the liver. That is, the Hashimoto receptor on hepatocyte or macrophages in the liver might destroy the platelet directly, which is depend on glycoprotein 1b specific antibodies. If one patient have these antibodies and the Hashimoto receptor might be activated and the hepatocyte might destroy the platelet. As we know that in ITP, platelets are mainly destroyed in the spleen, but also the Hashimoto receptor of the hepatocyte also destroyed platelet. So in conclusion, the pathogenesis of ITP is a loss of immune tolerance to platelet antigens. And the consequences of this divided into two. One is an overdestruction of platelet, which can be mediated by autoantibodies, cytotoxic T cells, and also Hashimoto receptor of hepatocyte. And the second consequence is that the antibodies or cytotoxic T cells might target the antigen on megakaryocyte, which causes a deficient platelet production. So ITP, we call it a double hit immune disease, which can be targeted, can be managed, treated with both anti-humoral immune agents and anti-cellular immune agents. Thank you.